treatment specialist and clinic owner. He's passionate about advancing ethical practice and strengthening trust between professionals and patients. Thank you. Welcome, Thomas.
I want to thank Maggie and I want to thank AHIP for inviting me here for the second year. It's an honor to speak in front of a group of my peers. What we're going to talk about today is something that I am very, very passionate about. I have been helping people hear better for over 35 years. And when I get up in front of a group of people like yourself, some of you I know, some of you I'm just getting to know. But if you love to help people hear better as much as I love to help people hear better, then you know me better than my own mother knows me, and I know a little bit something about you. See, the people that do what we do are special. And I don't say that because I want to build you up. I say that because the empathy that we have to do our jobs on a day-to-day basis is not something that can be taught. Either you have it or you don't. It's organic, but it's not man-made. And the reason why I say that is because the empathy that it takes for us to put ourselves out there every single day is not something you can fake. It's not something that you make up when you come to work every morning. I remember years and years ago, my youngest daughter, Julia, saying to me, "Daddy, you work hard." And I thought about that for a minute. And I said to Julia, Julia, I don't work hard. I said, I work a lot. I work a lot of hours. People who build houses work hard. People who make roads and dig ditches, they work hard. That's physical labor. I go to work every day in pretty much an air-conditioned office, as most of you do. I sit in a room that's pretty comfortable with comfortable chairs, and I get to take the people in front of me and improve the quality of their lives. That's a gift. And so for us to be able to do that, we need to bring a certain presence with us every day. And that's what I'm going to talk about today. I'm going to talk about the integrity and the professionalism that it takes to be able to do what we do. See, years ago when I got into this business, I did not want to be a salesperson. I did not want to be a salesman. I did not want to be somebody that was selling a product. And I found that in our profession, some of that goes away. Some of that is masked by us having to dispense a product for quite a large dollar amount. That salesperson aspect becomes a stumbling block. And I always believe that if we presented ourselves as medical professionals and had clinic integrity, the rest of it would take care of itself. And that's what we're going to talk about today. Session objectives, recognizing the role of clinical integrity, identifying best practices in hearing health care. What does that mean? We're going to go through that step by step. Some of this may be remedial to some of you, and that's what I want today. Because yesterday, we had Bobby Joe talk about open-ended questions in her presentation. And how do we take that patient along the journey? How we take them along this journey is by representing ourselves as clinicians, as medical professionals, and applying these principles to entrust positive outcomes. What does that mean? It can take a lot of different forms. We'll talk about that. What's the definition of integrity? The quality of being honest, having strong moral principles, and maintaining consistency of one's words and actions. Basically, what is integrity? Doing the right thing even though no one's looking. How many of us, when we're done shopping, put the shopping cart back? I love all of you. Why is that important? It's integrity. You're saying, I respect the person that's coming behind me. Nobody's watching you, but you put the shopping cart back when you're done. That's important. All right. Section 1, set the stage for the appointment. This is where we start to establish our integrity and our professionalism. By setting the stage, are we doing a comprehensive case history? What does that mean? Are we asking the patient about their physical anatomy of their ears? And why are we doing that? Have you ever had any surgery done to your ears? Very important question to start out. You are establishing yourself as the medical professional. In the last 90 days, any infections or drainage from your ears? In the last 3 months, have you noticed any rapid loss of hearing at any time? Any chronic or acute dizziness or vertigo? Why are those questions important? Because we're establishing ourselves as the clinician. Now the journey begins. And what that is you're setting yourself up for the prognosis at the end. Comprehensive case history. Then we do otoscopy. How many of us have had patients sit in front of us, and after we looked in their ears, they said to us, well, they didn't do that at the last place? A lot, right? And when we look in the ears, are we doing just the cursory drive-by with the light? Are we actually looking in that ear? And are we identifying landmarks? And are we letting that patient know what we see when we look in their ear? What are those bony growths called in somebody's ear canals? What's that called? Thank you, exostosis. What is that? That's most often somebody that has swam a lot. That's most often somebody that has been a swimmer and that has swam in cold waters. And so when you look in somebody's ears and you see that bony growth and you say to them, oh, were you a swimmer? And they look at you and they go, how'd you know that? What did you do? You established credibility. They said, this is somebody I want to listen to. They know a little bit about me and my ears. Just by looking in my ears, they asked me if I was a swimmer. How about when you look in somebody's ears and you see the tympanic membrane and it's got some milky white over it? Do you ever ask them, hey, did you have a lot of ear infections throughout your life? And they go, yeah, I did. Yeah, your eardrum tells me that. What just happened? Credibility. You became the professional in the room. And that's what's so important as clinicians. Explanations of test procedures. How often do we put our patients in the booth and we tell them what's going to happen next? I'm going to put these circular headphones on you. I'm going to put these inserts in your ears. I'm going to play you different sounds at different tones. And what I'm looking for is what's the softest you can hear each sound. Clear explanations of what's going to happen. Complete diagnostic evaluation. I'm going to ask you another question. How many patients have come to your office? And I know you folks are serious about what you do because you stayed here for the last session. And I thank you very much for that. But how many patients have come to your office and you got done testing them and they looked at you and they said, I've never had anybody test my hearing like that before. Right? Boy, two things happened to me. One, I'm proud, and two, I'm sad. Right? One, I'm proud because I'm going to do that job every time you come in. And two, I'm sad because the rest of our profession isn't doing it the way that they should. But that sets us apart. That sets us apart from the clinician who's just mailing it in every day. Do you want to be good or do you want to be great? We want to do that comprehensive test to set us apart. Complete explanation of test results. This is where sometimes we can get a little long-winded. I can. Okay? What does a patient want to know? How am I hearing? I mean, two things they want to know when they come in our office. Is my hearing bad enough for hearing aids, and how much do they cost? If you could answer that in the first 5 minutes they were there, they'd get up and go, right? That's why this process is so important. Because they have decided today to come in your office. It took so much for them to get there. They don't want to be there. Do you know that? I swear, nobody in the 35 years that I've been doing this has been lined up down the sidewalk outside my office on a Monday morning saying, I finally got here. Do I get to get those hearing aids today? Doesn't happen. They're reluctant to be there. And that's why this is so important. A solid recommendation after we go through this process. Oftentimes we describe but not prescribe. What does that mean? Well, we tell them you have a significant hearing loss, you're having problems in speech understanding, and it's probably going to get worse. Have a good day. They came to us for treatment. They came to us for a solution. They're afraid. They might not like the solution, but they came into our office today looking for some type of relief from this pain that they are not only causing themselves, but the people around them. And that we need to tap into. Shared decision-making by patient and provider. Recommendations are driven by the patient's needs and goals. I learned not soon enough in doing this that if I listen to my patients, they will tell me how to help them. If I learn to listen and not listen to talk, I will help more people. Experience is what we get when we don't get what we want. Think about that for a minute. How much experience do we have in not helping people? 6 out of 10 people, 5 out of 10 we've heard, and maybe it's getting better, but 5 or 6 out of 10 people that come into our office leave without help. Why? Because they didn't trust us to help them. It's that simple. So where does integrity come from? It comes from not high-pressure sales tactics, not recommending something that's not going to fit in their lifestyle because I didn't listen to what they were saying. How do we explain prices to people? Do we talk about directional microphones? Do we talk about Bluetooth capability? Do we talk about rechargeable? Do we talk about the compression in the hearing aid? Because if we do, they glassed over about 3 minutes into that. We got 3 levels of technology: basic, mid-level, and advanced. I'm going to walk you through this, and both of us are going to decide what's going to help you better. Basic. They're $4,500 for the pair. You're going to hear better at home. You're going to hear better one-on-one. You're going to hear the television better. This is for somebody who's pretty sedentary. This is for somebody that doesn't really leave the house a lot. Well, immediately, somebody's going to say, well, that's not me, right? Maybe it is. But most people that are in your office don't want to be that person. So let's go to the second level. They're $5,500 for a pair. You're going to hear better at home. You're going to hear better one-on-one. You're going to hear the television better. And you're going to hear better in small groups of people. You're going to hear better when you go to the grocery store. You're going to hear better when you go to doctor's appointments. Oh, okay. That's more like my lifestyle. Then the third level, which is the highest level of technology, they're $6,500 for the pair, and you're going to hear better everywhere you go because they have more speech to noise suppression. You're going to hear better in a noisy environment. Isn't that pretty simple? When we go any further than that and we start to talk about all the features and all the things that we know the hearing aids do, and they process sound certain ways, and now they have 2 sound processors in them, one for speech and one for noise, you know what the patient's saying? I need to go home and think about this. You know, I tell you what, Kathleen, I'm going to get back to you because I'm going to go talk to my neighbor, and then I'm going to go talk to my son, and then I'm going to go find out what Mrs. Jones is wearing, and then I'll get back to you. Because you know what we did? We made it too confusing for them. If we want to help more people, we need to make this simple. And the way we make it simple is to have transparent pricing and clear expectations. How many of us use verification tools in our office? Wow, you guys are awesome. I love verification. I can tell you you're hearing better. Your family can tell you you're hearing better. Does the technology tell you you're hearing better? And more, people want to know that. I don't know if any of you have noticed in your offices, our patient population is changing. You know, we've been hearing about these baby boomers, right? I've been hearing about them for 30 years. Can I tell you something? They're here. And here's what, you want to know the secret to treating a baby boomer? I'm going to share it with you. The doors are closed, right? Here's the secret. Make them feel special. They're the easiest population that we have ever fit. The greatest generation, they followed the medical model. The silent generation, those hearing aids cost more than their first house. They can't imagine that they're going to spend $6,000 on a pair of hearing aids. Now, here comes the baby boomers. They have more discretionable income than any group of patients we have ever sat in front of in our entire history. And you know what they want to know? That you care. That's what they want to know. They're about relationships. They're about technology if they embrace it. And they're about feeling special. And if we can make them feel special, they will be our patients for life. Recognize that. Recognize that when they walk into your office. Hey, Bobby, how you doing? Come on. I'll be with you in just a few minutes. He's beaming. Tom knows me. Yeah. Sit right down. He'll wait 20 minutes for you because you recognized him. That's the easiest group of people we're ever going to fit. Counsel on realistic expectations and device handling. Does anybody use a wearing schedule in here for first-time wearers? I want you to think about that. How many patients say to us, never wore hearing devices before, do I have to wear these all day? Right? How about you take them off the hook? Tell you what, Mrs. Jones, I'm going to put together a wearing schedule for you, and I want you to wear them for 2 hours a day for 3 days and only at home. Then I want you to wear them for 3 hours for 3 days and only at home. Then I want you to wear them for 4 hours and 4 days and only at home. Now, there's different thoughts about this. People say, put them on, let them walk out the office with them on. I get that. But let's remember, this hearing loss is something that's happened most often, very gradually, over a long period of time. And what's most important the first time they wear hearing devices is acceptance. Because if they have a bad experience, we're not going to see them again for a while. So if I put those hearing devices on Mrs. Jones and she's never wore them before, and she walks out of my office and a bus goes by, she's not going to be happy. Now, that bus isn't any louder than you and I hear it, but she hasn't heard it that way in 5 or 10 years. So if I tell Mrs. Jones, you're going to take these home in the case, and you're going to put them on when you get home, and you're going to wear them watching TV tonight. I just took her off the hook, right? Now there's more acceptance. And then when I see her in a week for her follow-up appointment, I'm going to say, now you can wear them outside the house. And we're going to go over that at her fitting. Validate with outcomes. How you hearing? How you hearing in church, Mrs. Jones? How you hearing your family? Let her tell you. Let the patient tell you. We talked about this, and this has to do with clinical integrity. When a patient comes to our office and we can't help them for one reason or another, what's our follow-up procedures for tested, not treated? Do we dismiss them because we couldn't help them today? And then I want to take this a step further. Do you know that patient is embarrassed to come back and see you when they didn't get hearing devices from you for the first time? Because you said to them, Mr. Roberts, you need help for your hearing. And it's something I know that you've been putting off for a long time. Mr. Roberts says, I'm not ready to get help for my hearing. And you say, okay, well, I'll be here when you are ready. But you know what? Mr. Roberts is embarrassed to come back in because he didn't get help from you. How many people like to be wrong? I don't. Now, when Mr. Jones or Mr. Roberts has to call your office back up again and say, can you get me back in with Sarah? I want to get those hearing aids now. Very rarely is that going to happen. But if Mr. Jones is given an out, which is, I tell you what, Mr. Jones, I'm going to make an appointment for you, and I'm going to see you in 3 months. But now you don't have to wait. But I want to make sure that I'm doing my job for you. And my job is you came into my office today looking for some type of help. And some way or another, we didn't get to that. That doesn't mean I don't want to help you in the future. Open up that door. Don't close it. Make an appointment for that patient. Do you know your patients are your equity in your office? It's not the audiometer. It's not the booth. It's the patient. We've heard over the last few days how marketing costs have gone through the roof, right? Do you know it takes close to $1,000 right now to get a new patient to come into your office through direct mail? An organic patient that has never been in our offices before costs close to $1,000 in marketing to get that patient to walk through our front door. That doesn't mean they got hearing aids. That means they just came in for an appointment. And now we're going to let them leave without their next appointment? The equity in each one of our offices is our patient retention. No patient should leave our office without some type of follow-up appointment. Let's say I couldn't get the cerumen removed today and I had to send them home with some softener. Did I make an appointment for them to come back in a week, or did I tell them to call me when they feel like the wax is softened up? If I didn't make an appointment, that's bad on me. I lost that patient. Who knows if they're going to come back? How about when I send them out for a medical referral? Do I make an appointment for them in 30 days? If I don't, that's bad on me, because I am not utilizing that patient that walked through that door. And the thing is, if we're going to stay helping people, we need to keep them tethered to our offices. So this is one of the things that I stress so much. This is ethical patient care. Section 2, professionalism in hearing health care. Definition of a professional. And this is what I started out with when I first talked this morning about raising the level of ethics and professionalism in our industry. What is a professional? Somebody who is trained to do their job well, who has good judgment and polite behavior. I want to believe that's everybody in this room. Why? Because we talked about ethics before, and I saw a lot of you with your heads going like this. And I know that's important because you stuck around again to the end here. And you said, maybe if I can just get one more nugget to take back to my office, I might be able to help one more person next week. And hopefully today, when we're done with this talk, there's something that you can take out of here and put into practice Monday when you go back to your offices. Because the ethics and the professionalism that we get to display every day carries our industry. You and I are the gatekeepers of hearing healthcare. And the way we present ourselves is what's going to continue this profession. Professionalism is competence, ethics, and communication in action. We must set expectations and build trust from contact. Isn't that what we talked about in the case history? Isn't that what we talked about when we did otoscopy? See how this all comes together as we present ourselves as hearing care professionals. What are characteristics of a professional? These are things that over the years I've seen some clinicians do really, really well and others not so much. And what I mean is that patient comes into our office. We want to have neat appearance. We want to have a lab jacket on, a white coat on. Why? Not to make them scared, but to let them know we're the medical professional. Proper demeanor, cheerful. Remember, some patients may be hesitant to be in your office. I talked about that earlier, didn't I? They don't want to be here. They don't want to come and see us. And they certainly don't want to wear hearing aids. So what is our job? Our job is to uncover why they came to our office. Again, Bobby Joe yesterday talked about open-ended questions. I love that. Why? Because they're engaged in their own health care. None of us like to be dictated to. None of us like to be told, this is what you need to do. But what we do like to have happen is part of the process. And if I listen to you, I'm going to say it again. As my patient, if I listen to you, you will tell me how to treat you. You will tell me why you came to my office. But am I willing to listen to that? Be competent. Express confidence, but not arrogance. That has to do with listening. Long, long time ago, I learned I don't have to be the smartest person in every room I go into. And let me tell you why that's so important. First of all, it's exhausting. When you got to be the smartest person in every room you go into, that's a lot of weight to carry. And the other is, if we always do what we've always done, we will always get what we've always got. If we keep doing the things the way that we're doing, we're going to stay at a certain level. Now, that level may be high, maybe medium, maybe low. But how many of us want to exceed whatever level we're at? So if we've always do what we've always done, we will always get what we've always got. One of the things that bothers me is, and I remember this when I was younger. I remember being a baseball player, right? And they used to say, Tommy, you need to try harder. I'm trying, man. Tommy, you need to go up there and swing that bat harder. I'm swinging that bat as hard as I can. I'm going to pose this to this group today. Stop trying so hard. Try something different. I need to learn to swing the bat different. I need to listen to patients differently. I need to read the room better. I don't need to keep pushing harder. So stop trying so hard, please. And whatever you're doing, do it a little different. Do it a little better. Be conscious of what we say to our patients and how we listen to them. If we're always listening to respond, we're not listening to hear. And they know that. So it's okay for affirmation. When a patient makes a statement to any of us, don't respond. Let it marinate. When a patient says to you or I'm really having a problem hearing at the dinner table when my grandchildren come over. Let that sit for a minute. Because that's that patient allowing him or herself to be vulnerable. And you know what it took for them to be able to say that to you? It took a lot of guts. Let them know that you care. That's where the arrogance goes away. Exercise good communication skills. Keep your tone polite and formal. Enunciate in a lower tone. Probably enunciate is the most important thing that we can learn as a hearing care professional. My wife tells me constantly, honey, the way you talk is painful. Yeah, it's true. My mother was somebody who had a very good sense of humor, and when we were younger, she made us enunciate. She did, and I thank her for that today. I didn't thank her for it when I was 4 years old and didn't have any front teeth. But does anybody remember the French's or Lee and Perrins made it, and it starts with a W, and what's that called? What's that? Worcestershire, huh? There are no such syllables as Worcestershire. It is called Worcestershire sauce. That was my mother. And can you imagine being 4 years old, and if you wanted that sauce on the table, you had to say, Worcestershire sauce. Now, it's not pronounced that way. But my point is this. If you enunciate, people are going to listen to you better. Why? Because they don't have a problem hearing you. That's why. How many people come into each and every one of our offices and say, if everybody spoke like you, I wouldn't need hearing aids? Right? Yeah, well, you're a trained medical professional. You have learned to talk like this because you don't want to yell at people all day long, right? And people don't talk like we talk. People don't say Worcestershire sauce. And that's why we have a place within the medical community. Come on. Be prepared for when your patients come into your office. What does that mean? Again, you're showing competence. You're showing professionalism. Do not repeatedly open and close cabinet doors or drawers. How many of us know where everything is in our office? Or when we're sitting in front of a patient, we're opening and closing drawers, or we're going through cabinets. Have you ever gone into a medical professional's office? Let's say you're going to have some stitches taken out, right? And you go in there, and the doctor starts looking for his tools. And you're sitting on that bench, and you're going, oh, boy. Now, this guy's going to do a medical procedure on me, and he doesn't even know where his scissors are. Do you know our patients are thinking the same thing when we're looking for domes and wax guards? Our patients are looking at us and going, I'm going to let this person take care of my hearing, and they don't know where the things are in their offices? Move slowly. Move deliberately. Try not to make any sudden movements. Why? It scares them. Move slowly. Move confidently. What are you doing? Instilling confidence in the patient that you're in charge. You know what is best for their hearing health care. If you need to leave the room, don't rush out and rush back in. How many of us do that? Blow through the door, they blow back in again. The patient's sitting there like this. Oh my God. Yeah. Scared the heck out of them. We know where we're going, right? They don't. You know, we do that 2 or 3 times during the appointment. The patient's like, I got to get out of here. I am scared to death. And then we turn around and say, that'll be $6,500. And they go, what? How many of us have gone to program a pair of hearing devices brand new, and we don't have the proper software installed on our computer? I have. All right? And then you turn to the patient and you go, it'll just be about 25 minutes. I just got to download this from the laboratory. It'll be just a few minutes, right? And the patient's looking at you going, you couldn't have done this before I got here? Right? And that's because we didn't do our homework, right? And we're not instilling professionalism or confidence in that patient when these little things happen. And these are little things, but when they add up, they're taking away from our competency. And this may be remedial, like I said earlier, but I break it down so I can get each and every one of us to recognize what are we presenting to that patient once again who doesn't want to be in our office. That's why this is so important. Lead the patient. Do not be led. This is, again, I want to establish when you come into my office that you are in good care. And I'm going to take control of that appointment. And how is that? That when I come and get that patient from the front desk, that I lead them down the hallway. I'm not behind them walking. Yeah, Mrs. Jones, yeah, the second door on the left. No, Mrs. Jones, follow me. You know what Mrs. Jones says? Oh, thank gosh. I don't have to figure out where I'm going. This person's in charge, right? Direct the patients and the family to where to sit in the room. How many of us have them come into our consultation room and they don't know where to sit? And they're doing this, and they're doing this. And you know what's happening? They're confused and they're feeling uncomfortable. And we made them feel that way because we didn't say, Mrs. Jones, come on in here. And you tap the back of the chair and you say, Mrs. Jones, I want you to put your little tiny hiney right here. And what does Mrs. Jones do? She sits right down in that chair. Mr. Jones, come on right over here. And he sits down right in that chair. And what did you do? You established that you were in charge. And they love that. Ooh, I love this healthcare provider. When you go to the doctor and he says, hey, Tom, you got diabetes. You might want to think about changing your diet. No, he doesn't say that. He says with confidence, Tom, your testing today showed me your blood sugar is high, and if you don't do something about it, bad things are going to happen. And you know what we do? We go, oh, okay. What do I need to do? Right? So when that patient comes in your office and you establish that you're in charge and you say, come sit right here, that's a directive. And they love, that's why they came to see us. Stay away from discussing controversial topics. Stay away from religion, politics. Why? Our older patients love to draw us into those conversations, don't they? And I got to tell you, it's a lose-lose. Doesn't matter what side of the aisle we're on. Doesn't matter what fence it is. Doesn't matter. It's not why they came there. What they're trying to do is deflect the reason why they came there. What we need to do is direct the patient back to the reason why they came to our office. Enhancing our professionalism by changing our terminology. This is so important to raising the level of esteem in our profession. And we do and describe things within our profession because we've been taught this way. Now, what do we have to do? We have the opportunity to change that. And why do we want to change that? To elevate us as medical professionals. Think about the verbiage we use on a day-to-day basis. Hearing devices are made in a laboratory, not a factory or a manufacturing facility. I will tell you, the hearing device laboratories are some of the biggest offenders in this. They call it manufacturing. Has anybody ever been to Oticon? Anybody ever been to Starkey? Anybody ever been to a hearing aid laboratory? Anybody? When you go in there, you see people in white coats. You see people with microscopes. You see very well-lit rooms. What do you think of when you hear a factory? I'll tell you what I think of. I think of guys in greasy overalls, got some chains over here, got some fire in a cauldron going on. So when we describe it as a factory, are we really giving it the professionalism? No. That hearing aid is not made in a factory. It's made in a laboratory. Let's start calling them laboratories. It raises the level of professionalism. Use terms like hearing devices, not hearing aids. Nobody wants to wear a hearing aid. Nobody wants help. They want a hearing device. And again, that gives it a better connotation. Avoid using the word free. This is one of my pet peeves. I hate free. Why? Free has no value. What you folks do every day has value. And when we say, oh, that's free, you know what? It doesn't have any value. How many patients, when you are done at the end of their appointment, say to you, what do I owe you? That's because you have value. And as soon as you say to them, oh, no, that's free, you just took away all the value. So what do you say? You say, that's no charge today. Or this is a professional courtesy. Or this is part of our prearranged agreement that I would take care of you every time you came in, as long as you entrust your hearing to me. That's building confidence. That's professionalism. Free is something that they're not going to appreciate. Well, it didn't take much. Look at Kathleen. She fixed my hearing aid in 5 seconds. Must not have been that broken. No, Kathleen knows how to fix that hearing aid because she's been doing it for 20 years. And she knows how to change that dome and how to change that wax guard. And that's something that the patient appreciates. But when we tell them, it's free, we've really undermined our own value. What we say and what our patients hear, two different things. Let's go back to the beginning of when I talked to you today about the empathy that it takes for us to do our jobs. And sometimes, as much as that's appreciated, it can be a detriment. Because we try to make things maybe a little bit too warm and fuzzy at times for our patient, rather than just being truthful. And what we say and what our patients hear sometimes is very conflicting and very confusing to them. We unintentionally say things like when we open up the test booth door and we take those inserts out and we take the headphones off and we look at them and we say, you did good. Now, what did we mean? We mean you pressed the button when you were supposed to press it. You raised your hand when you heard the tones. You repeated the words back the best that you could. That's what we meant, right? But what they heard is they did good on their hearing test. Now, that's us being kind, loving, and caring, right? And we want to tell them, you did good. You did. But you know what we did? We just confused them. And we don't mean to do that. But again, that's our nature. Your hearing hasn't changed. Oh, we love to tell patients that, don't we? They're in for their 4 or 5 year annual test. We know there's better technology out there. But we tell them, your hearing hasn't changed. What did the patient just hear? They don't need new hearing aids. Well, Tom, you just told me my hearing hasn't changed. And what we're trying to say is, I can tell you're wearing your hearing devices, and that's really helping you in maintaining the hearing that you have. That's what we wanted to say. But what we said is, your hearing hasn't changed, and what they heard is, I don't need new hearing aids. Your hearing has remained stable. Another statement that we make with not knowing the implications. Your hearing has remained stable, which means you don't need new hearing aids. How many of us can say that hearing aids are not better today than they were 5 years ago? They are. We know that. The technology is better. The separation of sound is better. Their hearing may have remained stable. Their hearing may have not changed. but can their speech understanding be better? And if we make statements like that unintentionally, we're sending a message that we're going to have to backtrack on if we want to help them hear better. And now we've confused the patient. Your speech discrimination or understanding is very good. We love to tell them that, don't we? Oh, but your speech scores were good today. Do we follow that up and say, your speech scores were good today at a level that is 4 times higher than normal conversational speech? They scored 92% in their right ear and 88% in their left ear at 70 decibels. What's normal conversational speech? 45 to 50, right? So if they're at 70, do you realize that's 3 times louder than normal conversational speech? When we change a signal by 6 decibels, we're making that signal twice as strong as it was. If you and I were watching television together and you said to me, Tom, go make the TV twice as loud as it is, I'd raise it 6 decibels. So when somebody's hearing at 92% at 70 decibels, that's more than 3 times louder than normal conversational speech. But then we say things like, but your speech understanding's good. Do we follow that up with an explanation? Or do we just leave it alone and not confuse them? We don't mean to do it. What should we say? When a patient asks, how did I do? The answer should always be, if it's appropriate, you have a significant hearing loss. And then the patient says, well, has my hearing gotten worse? Right? They want to know that. You still have a significant hearing loss. You may hear the tones the same, but we're always going to focus on your ability to understand speech. Very rarely do people come into our office and say, I can't hear the fire engine. They may have waited too long to come and see us, right? But what they will say to us is, I can't hear my grandchildren. And if there's something out there, and I've been wearing hearing devices for 5 years, and I can hear my grandchildren better, don't I have a responsibility ethically to tell them about that? And that's where some of these statements that we make confuses our patients. Think about it, okay? That kind, loving, and caring that we all are from the inside sometimes gets in our way, and then it gets in our patient's way. And we don't get to move them to a place of better hearing because we've confused them. Think about that. If we want to be perceived as medical professionals, we have an opportunity to change the way that we talk to our patients. And those slides that we went through today, if you take one thing out of there and you implement that on Monday, you're going to start to raise your level of professionalism. It's the terminology that we use. What we say and how we say it is how we change our professional persona. Be that hearing healthcare provider that you want to be. And the way to do that is to be ethical and professional. I'm going to leave you with this. In 2034, there will be more people over the age of 65 than under the age of 21 in Canada. There will be more people with discretionary income to spend on their health than there ever has been in the history of time. If you want to be that medical professional that they come to, establish ethics, establish professionalism, and keep them tethered to your office by follow-up appointments, and you will be a successful hearing care practitioner. I want to thank you all for being here today. I want to thank you all for staying, and I hope you got something out of our talk. Thank you. Any questions? All right, enjoy your gala. Oh, you're welcome.